think we're all waiting to listen to Dr. Stone, and we thank once again. And over to you, sir. Your topic is the same, sir.
Well, great. Well, thanks. I'm glad that my talk title didn't change and I didn't know about it. So let me share my screen.
Ajay interchange with George Dangus.
Okay, you should be seeing my slides. So I'm going to comment the issue of that Ajay discussed, but a little bit differently. And that is how to improve outcomes, or can we improve outcomes by choosing different types of stents? And there's a lot of different types of stents that are out there, and they're constantly evolving. They have been for the last 30 years. So how can we make a difference in our patient outcomes by improving stent selection? These are my relevant disclosures. So it's, just historically looking back, we've come a long way in terms of stent design. These were actually the first two widely used stents in the United States, the Cook GR2, which followed up from the GR1, this clamshell design, and the articulated Johnson & Johnson Palma shot stent. You could see these approved in 1993 and 1994 by the FDA. And when you look at these are so rudimentary. I mean, it's just hard to believe that this is what we were putting in our patients back then. But they amazingly worked. They were really designed initially to prevent acute closure, and they did work because they sealed dissections. But of course, the Achilles heel of these bare metal stents was restenosis, which, as we treated complex lesions, would occur in 50% of patients due to all the neointimal proliferation that would develop after medial injury. So we then decided to put a drug, an anti-proliferative agent, on the stent, and we used a polymer to control the dose and the release kinetics of the drug. And of course, the first two drug-eluting stents were Cypher and Taxus. Marty led the Cypher program. I led the Taxus program. These were FDA approved in 2003 and 2004. These were originally fairly thick strut stainless steel stents. The polymers were not particularly biocompatible. Sirolimus is a very well tolerated drug. Paclitaxel can be reasonably well tolerated, but it's got a very narrow toxic therapeutic ratio that Boston Scientific got right for Taxus. And we learned a lot from this first generation DES era, particularly when these things worked. They were absolutely amazing. And they would allow you to take the acute result that you would get from your bare metal stent performance and from preventing stealing dissections, preventing recoil, and then basically freeze the result at 1 year, 2 years, 4 years, 7 years. So really fantastic. And we published very transparently that even though these had great anti-proliferative effects, they weren't perfect, but they were very, very good. So target lesion revascularization, the purest clinical surrogate for DES efficacy, was reduced by about 50%. And this is from the summed Taxus program. So we made, again, major improvements. Of course, we introduced a new complication, and this was very late. That is greater than 1 year drug-eluting stent thrombosis, where you get a good result. It would look really terrific initially. The patient would be absolutely fine until suddenly 3.5 years later, the patient would present with sudden thrombotic occlusion of the stents. And we almost never saw this with bare metal stents. And again, we reported this very transparently. You could see, for example, looking at myocardial infarction in the Taxus program and stent thrombosis as well, within the first year, they were very similar between the two devices. But then between 1 year and 5 years, you could see the curve separating with a higher risk after the first generation drug-eluting stents, both Cypher and Taxus. And we even published this in the New England Journal of Medicine. We learned a lot as to what were causing these early events, which informed future drug-eluting stent design. First of all, delayed healing was very important. Bare metal stents would completely endothelialize, where 6 months after drug-eluting stents, only about 40% of the surface would be covered. We saw that the polymers and in some cases the drugs were inducing inflammatory reactions, eosinophilic or giant cell infiltration. There was abnormal vasomotion distal to the stents. And probably most importantly, the polymer and the drug would sometimes cause vascular toxicity, which would cause acquired malapposition. The vessel would just basically grow to try to escape the stent. The stent would be floating in the lumen, and likely not due to that effect, but more due to the underlying inflammation in the vessel, we would get this very late stent thrombosis. So this led to the development of second generation drug-eluting stents, and we tried to address all the different aspects of the three components of a DES. We basically moved to the limus drugs, and pretty much that's been persistent ever since this time, because again, they're extremely safe and they have a very wide toxic therapeutic ratio. But very importantly, perhaps the biggest difference was we went to very biocompatible polymers. I led the Xience and Promus element programs in the United States, and I can tell you these are very elastomeric polymers. They have almost no vascular reactions on histology. The Resolute program, initially Endeavor, but then going to Resolute, have a very interesting copolymer dual layer called BioLinks, again, very biocompatible. And importantly, we went to better stent platforms. We thinned out the stent struts. We went from stainless steel to cobalt chromium, which is much more malleable and still has good radial force, to induce less neointima just from the injury from the metallic stent itself. And also the lower stent strut height would lead to more rapid endothelialization. And sure enough, this led to improved outcomes. And again, this was from the Xience stent program, 4 different trials. We put them together in a patient-level pooled database. And you can see, looking at, for example, 2 years, the overall incidence of MACE, cardiac death, MI, or TLR, was substantially reduced, both by Xience compared to Taxus. And you could see it was an early difference, so they were safer in the peri-procedural and 1-month period, and then the curve spread over time. And I think what was most impressive was there certainly was greater effectiveness, with about a 1/3 reduction further in effectiveness. But the biggest difference was safety. These devices, particularly I think because of the more biocompatible polymers, were much safer. And you can see stent thrombosis rates, which always about 2/3 of them occur within the first month, were reduced by about 2/3 overall in 2 years with Xience compared to Taxus, from 2.3% to 0.7%. So now we've really got safe devices. They're more effective, and we can really start treating more complex disease. So do we need better stents as we're in 2021? Why does industry keep spending a lot of money and time and running large trials to iterate stents? And I would argue that we do need better outcomes. The question is how we get them. And why we need better outcomes is to further eliminate early and late stent thrombosis and restenosis. They're not yet zero, neither of them. To reduce the dependency on long-term dual antiplatelet therapy, and Ajay talked about a lot of that, but certainly in still complex anatomy in high-risk ACS patients where you've got ongoing inflammation and activation of the coagulation system and a lot of metal that's prone to thrombose. We still, again, have situations where longer-term DAP does reduce those adverse ischemic events. And we want to improve the lifelong prognosis after drug-eluting stents as relates to the stent. And this one is really important and still not as much appreciated, although recently several groups are publishing on this. This was from our work. We put together 17 randomized trials and 22,000 patients. See, as we've gone from bare metal stents to first generation to second generation DES, target lesion failure rates, these are events that are coming from the stent, as best as we can tell, have gone markedly down, especially from being MS to Cypher and Taxus, but then also, of course, with second generation DS. But what's interesting is if you look from 1 year to 5 years, you see that all 3 stent types have about a 2% per year event rate after year 1. And these are events arising from the stent that are still late stent thrombosis or late restenosis. And we used to think that with bare metal stents in particular, once you got out to 1 year, you were essentially invulnerable. The patient, nothing would happen to them. But actually, that's not really true. And now we know that they clearly are late restenosis and thrombosis events, even with bare metal stents. In fact, first generation DES made this a little bit worse. That's the 9.5%. Second generation DES brought it back down to about 2% per year. And this has now been seen out to 10 years. This was from one of the ISAR test 5 studies, 3,000 randomized patients, randomized to 2 different types of drug-eluting stents. And again, you see what happens within about 1 year. But then again, from 1 year to 10 years, you see this linear increase in target lesion failure events. Here, with a more unrestricted patient population, it's about 3% per year. And it's linear and it keeps going. Data from Japan out to 20 years suggests with bare metal stents, it keeps going. So, what is the etiology of these? Some of this is neoatherosclerosis, some of it is late stent fracture, some of it is ongoing polymer reactions and ongoing inflammation and thrombosis from platelet adherence and lack of coverage, et cetera. So can we improve these long-term outcomes as well as the short-term outcomes? So how can we further improve metallic drug-eluting stent outcomes? Well, one, we could make the stent struts thinner, okay? Because the thinner the stent struts, the less medial injury there may be just from the stent implantation. And again, the more rapid endothelialization will be. Two, there's the concept of using bioabsorbable polymers. If the polymer is causing inflammation, perhaps removing the polymer after a certain amount of time and restoring the bare metal stent surface will eliminate some of these very late events. And if the polymer is the problem, perhaps we should just eliminate the polymer altogether and just insert a drug-coated stent that does not have any polymer. Maybe that will be the safest. And of course, the fourth way would be eliminate the stent altogether, which would be bioabsorbable stents, but I won't talk about that because of time for the rest of this talk. So let's talk about how metallic drug-eluting stents are evolving. This is kind of an expanded picture of the one that Ajay showed. Looking at the early generation to newer generations, you can see we went from paclitaxel and sirolimus to now almost exclusively sirolimus analogs. The polymer material and thickness changed from a lot of durable polymers to a lot of biodegradable polymers. And you can see, though, variable thickness, some of them extremely thin, some of them substantially thicker. And then the platform material and struts have gone, in general, to thinner stent struts types to more, again, malleable struts, such as cobalt chromium and platinum chromium platforms. You can see how big, in retrospect, the early Taxus and Cypher stents were. So our outcomes improved with ultra-thin drug-eluting stents. You would have less side branch coverage, so maybe you'd have fewer periprocedural MIs, less turbulence, more rapid endothelialization to lead to less stent thrombosis and restenosis. That would be the theory. Well, we've done the recent meta-analysis because there's been a lot of work in this area. There have been 16 randomized trials, 20,701 patients with 2.5-year weighted mean follow-up, looking at the overall outcomes of what we can call ultra-thin DES, that is less than or equal to 65 microns, versus more classic second-generation DES, 81 to 120 microns. And you can see these 4 ultra-thin strut DES are Cyro, MyStent, Biomime, and Superflex. So several of these coming out of India. Should be very proud about that. The controlled DES range from Xience to Resolute, Integrity and Onyx to Endeavor, Nabori, and BioFreedom. And overall, target lesion failure was a little bit less with ultra-thin DES, with about a 15% risk ratio reduction at this longest term follow-up, although there is some heterogeneity between studies. When we look at the individual components of target lesion failure and target vessel failure, which are reduced, we see the primary reduction is in target lesion revascularization, which is clinically driven, where here there might be about a 25% reduction in target lesion revascularization. So this probably translates to about an absolute 1% difference in TLR. You'll note there's really no difference in myocardial infarction, although the point estimates are below 1. No difference in stent thrombosis, all the point estimates are below 1. Actually, interestingly, we did have a little signal towards a potential slight increase in all-cause death. This was both for cardiac and non-cardiac, but it did not reach statistical significance. And without a clear mechanism, I suspect it was due to a play of chance. So, our outcomes improve with bioabsorbable polymer-based drug-eluting stents. Again, once the polymer is completely resorbed, now you have a bare metal stent remaining, which should hopefully lead to fewer late and very late stent thrombosis events and possibly less late restenosis. And the polymers in these different stents are gone anywhere between about 4 months and 12 months, depending on the stent design. So polymers are not good for a variety of reasons. I already mentioned the inflammatory reactions that can occur, but also the polymer, again, holds the drug. And you need uniform polymer delivery to get uniform drug delivery. And less appreciated is that as you pass these devices through tortuous or fibrocalcific vessels, you can strip off the polymers. And you can get bonding, you can get webbing. Sometimes you can strip off large swaths of polymer. And this alone can lead to either be a nidus for thrombosis or can lead to restenosis. So we first published a meta-analysis of 89 randomized trials, 85,000 patients, looking at stent thrombosis and other outcomes with bioabsorbable polymer-based DES versus durable polymer DES. And while these devices were a little bit better than bare metal stents, they weren't any better than more contemporary durable polymer DES in any of the measures that we looked at. Perhaps the absolute best test of this was a single randomized trial, which involved the Synergie stent, arguably one of the best bioabsorbable polymer drug-eluting stents. It's relatively thin struts, 74 microns. It's very conformable. It elutes everolimus over 3 months, and it has the bioabsorbable polymer coating of PLGA, which is very thin on the abluminal side only, which absorbs within 4 months. So a very good bioabsorbable polymer stent design. And this was tested in the INVOLVE-2 trial of 1,684 patients randomized to the durable polymer-based Polymers element plus stent. And you can see there was absolutely no difference in target lesion failure, either early or late. And stent thrombosis rates were also identical between the two devices. So it really doesn't seem that compared to a good durable polymer, a bioabsorbable polymer makes any difference. Now, what about polymer-free drug-eluting stents? Maybe these are the answer. So the concept theoretically is that once the drug's eluted, a bare metal stent is left behind. There's no polymer. So this might lead to more uniform drug delivery. You don't have that polymer being stripped off. No adverse polymer reactions at all at any time period. And that might be important because remember, stent thrombosis is most common within the first 30 days and more rapid healing and shorter mandatory DAP duration. But there are potential disadvantages. It is difficult to control the drug and the elution rate from a bare metal stent. And it is possible that some polymers, particularly the fluoropolymers from everolimus eluting Xion stents, are thromboresistant and may promote healing. So the prototypical drug-coated stent, we don't even call them eluting anymore, we call them drug-coated if they don't have a polymer, is the BioFreedom stent. And this is a stainless steel platform in its early iteration. And you can see the abluminal side is micro-etched. And this creates a sub-architecture which is able to basically hold on to the drug long enough to get it to the site of the myocardial injury from the stent stuff itself. Again, this was a relatively thick stainless steel stent, 120 microns, and in early studies, the late loss was about 0.17 millimeters. The other thing to know is that it elutes biolimus A9, which is a limus analog, but compared to the other limuses, it's much more lipophilic. And that is to overcome for the fact that some of the limus is going to get washed off by the time the stent actually gets to the injury site. So again, this will deliver enough of the limus to the injury site to hopefully be effective. So as Ajay mentioned, this was tested in the Leaders Free trial. And the initial concept was that this stent should be the ideal stent for high bleeding risk patients because we knew that bare metal stents we would always treat with only 30 days of DAPT. And after 30 days, there was always a very low rate of stent thrombosis. So the Leaders Free investigators led by Phil Urban took 2,432 high bleeding risk patients and randomized them to either treatment with either a BioFreedom stent or a similar metallic bare metal stent. And they used 1 month DAPT only. And the primary endpoint for effectiveness was clinically driven target lesion revascularization. So do these things act like a drug-eluting stent? And the answer is they do. They reduced, you could see TLR by about 45 to 50%. And then the question is, well, were they safe? And the answer is yes, they were. And in fact, if you looked here, cardiac death tended to be reduced. In fact, myocardial infarctions were reduced with the drug-coated stent compared to the bare metal stent, with no difference in stent thrombosis. Although I will point out the 2% incidence of stent thrombosis at 1 year is pretty high with both of these different stents. So the question is, can contemporary drug-eluting stents do the same thing, even if they do have a durable or a bioabsorbable polymer? And again, Ajay went through a lot of the studies. Most of the contemporary DES have been tested now for short depth of either 1 month or 3 months in either registry or randomized trials. And we led the Onyx 1 randomized trial, which I think is important because it is a reasonably powered large-scale randomized trial of 2,000 high bleeding risk patients randomized to the BioFreedom drug-coated stent versus, again, the Resolute Onyx zotorolamus-eluting stent, which has a durable polymer and a cobalt chromium platform. And you can see there was absolutely no difference in the overall safety endpoint of cardiac death, MI, or stent thrombosis between the two stent types. And there was also no difference in effectiveness outcomes. And most of the stents that have been tested now have reported either very good registry and some randomized trial data for safety and effectiveness with only 1 month of DAPT. But as I mentioned, the BioFreedom is not a perfect stent because, again, the first generation thick stainless steel struts. And actually, if you look at an Allcomers trial, which did not consider using this for its bleeding risk characteristics, but just as a stent, this was an Allcomers trial called the Sort Out 9 trial in a large study of more than 3,000 patients, where stable CAD patients had 6 months of DAPT and ACS patients had 12 months of DAPT. And you can see here that the stent did not prove to be non-inferior. And while there were equal rates of cardiac death and target lesion MI, suggesting safety, that the Ultrathin strut Asyro stent compared to the BioFreedom stent had a clearly lower rate of target lesion revascularization. So again, the thinner the struts, the lower the rate of TLR will be. And this led to a clear difference in effectiveness between these two devices. So finally, I want to close to a common issue is what is the role of bare metal stents in the contemporary drug-eluting stent era? And actually, this is from a recent meta-analysis of 20 randomized trials of 26,000 patients. And believe it or not, there's actually been 20 randomized trials of bare metal stents versus new generation drug-eluting stents in a variety of clinical syndromes from stable CAD to ST segment elevation myocardial infarction. And the overall rate of cardiac death or myocardial infarction is actually less with drug-eluting stents compared to bare metal stents, about a 16% reduction. And if you look here, in addition, drug-eluting stents are even safer than bare metal stents. There's about a 1/3 reduction in stent thrombosis, and they're more effective. You can see in this meta-analysis, there's more than a 1/3 reduction in target vessel revascularization, almost a 50% reduction as well. So really, drug-eluting stents, the contemporary DES, this excluded Cypher and Taxus, are clearly safer and more effective than bare metal stents. So in summary, if I was to summarize where we are with stent technology in 2021, drug-eluting stents have gotten really good. Bare metal stents have no role in 2021. Take them off the shelf. But drug-eluting stents are not perfect. Iterative improvements are being made in stent configuration and delivery system construction, but it's difficult to further improve outcomes from where we are. Major outcomes can still be substantially improved by better technique. For example, intravascular imaging, physiologic guidance for lesion selection and lesion preparation strategies, and optimal use of pharmacotherapy, as Ajay mentioned, to balance this risk of ischemic complications versus bleeding. And future major clinical advances are going to require breakthrough technology. We were hoping bioresorbable scaffolds would be the solution to that very long-term ongoing risk of events that we've seen with every single stent, every single permanent metallic stent. And it remains to be seen whether or not newer iterations of bioresorbable scaffolds can break through again and deliver that promise. Thanks very much.
Thank you, Dr. Gregg Stone, for an excellent lecture. As usual, we have heard enough of stent talks, and we are excited to hear you again.